optic nerve that is exposing. You
Yeah.
are exposing the optic nerve.
Yeah. So now what I'll do is I'm going to open this space up.
You have gone to the chiasmatic part.
Yeah, I want to show you the chiasmatic part.
Yes.
The stalk, if you follow, that will take you to the chiasma actually.
Yes.
See these ligaments. Now you can see much better. See?
Okay.
Yes,
Okay.
yes.
We can see the ligaments.
Yeah. Can you see one vessel which is coming into view here?
Yes.
That is one of the branches of the carotid. Just give me a 70-degree scope.
Yes. Very good. Nicely exposed.
Can you see the chiasm?
Dura incision.
See this?
Yes.
So see the pituitary stalk is going between that. What is this? This is the basilar artery.
Basilar artery. Yes.
Okay? Can you see this? That is the basilar artery. This is the cerebellum here. See this?
Yeah.
Yes.
Okay, so what did I tell you? See, exactly in the midline. See? What a dangerous structure to have in the midline. When you are drilling the clivus, no, you have to be very careful. So here below, you will actually, if let me see if I can use a 70-degree scope. I'm very sorry, but see, because we don't have a drill, no, this is this is such a beautiful body, and I'm really feeling bad that we are not able to do justice to it. But I'll just try my best to show whatever I can. But we are going to have some limitations. Let me see with a 70-degree scope if I can show you. Otherwise, I think maybe we might have to stop at this level, because whatever else we want to do, we will require a drill. If you want to do transclival, or if you want to do a frontal sinus dissection, a drill out, all of these will require a drill. Give me a straight plate slip, please. Can you see this, sir? I'm using a 70-degree scope to go down.
Yes, sir.
Yes.
See that?
The basilar vessels.
Yes.
Yeah, so that is the basilar. Actually, if we retract this part of the brain, the cerebellum that you're seeing here, if we retract it, you will be able to see the 7th, 8th nerve complex. Give me this.
Can you give us the idea of the ICA?
ICA will be very deep inside.
Yeah.
It is close to the 7th, 8th nerve complex, no? I'm trying to dissect 1 second. No, I'm not able to, sir. See, this bone is coming in my way. Can you see? I need to drill this bone. Then I can push the cerebellum. See, if I push the cerebellum, you'll be able to see beautifully 7th, 8th nerve, ICA, everything I can show you. Huh? That's it. We can stop actually, because I don't have any more resources to drill this bone or anything. I think at the most I can probably do a optic nerve decompression and orbital decompression. That's probably we can do, because that bone below the this thing pituitary bone is very thick, and above the pituitary also the bone is very thick. So I will probably just show you how to do optic nerve and orbital decompression. Maybe after that, I think already 70% of the hall is empty. Okay, so
Sir, Guru,
sir,
still now there are many audience here. They are enjoying very much and very silently and very keenly observing the dissection.
Elevator.
And enjoying it.
Sir, next time I will get my own drill and come.
Okay, thank you.
That way we will be able to do better dissection. Really, if you give me this kind of cadaver, I'll stay back in Bangladesh and dissect every day. This is so beautiful. This cadaver is actually very nice. If we would have been able to dissect more, I would have loved it to have a drill and dissect. I could stay here till night also. I don't mind.
We think you are also enjoying, but
Oh, beautiful! I am really enjoying myself.
and it will be you would enjoy much if there would be a good drill.
Yeah, we could have done more work actually.
We have some limitation. There is no metabolic support.
No, don't worry about that, sir. What I'll do, see, I am a key opinion leader for Medtronic. If you are not getting support, just tell me. I'll get it for you.
Yes, next time.
Yeah, only cadaver will do. Only cadaver. I can teach you the whole anatomy, like from the olfactory nerve till the hypoglossal nerve. We can do the whole anatomy beautifully. We can dissect.
I think we should give more time to cadaver dissection than the live
Sir,
surgery.
at least one full day.
Then live surgery. Yes.
Yeah, one full day. Let us keep for this.
Cadaver
Instead of 2 days of surgery, we can do one cadaver and 1 day surgery. We can do.
Yes.
And we can remove all the lectures. Instead
Yes.
instead of the lecture, we can do dissection only.
Okay.
So what I have done now, I think you can appreciate the same thing that I had done in today's surgery, sir. That was the varicose carcinoma case. Can you appreciate, sir?
Yes,
I
sir.
have removed the whole of the medial wall of the orbit. That is the lamina pepraceae has
Lamina
been
paperaceae. You are
removed.
removing the lamina
Yeah,
paperaceae.
so see, I am going to ballot the eye. Can you see that?
Yes.
Yes.
So this is called as orbital decompression. Okay. So
Okay.
complete orbital decompression, you cannot stop at this. So if you observe carefully, there is a blue color thing here. Can you see?
Yes.
Yes.
What is this? This is actually the medial rectus muscle.
Yes.
Okay. I
Okay.
want you to appreciate one thing. See, in the anterior ethmoidal group of cells, so this is anterior ethmoid artery.
Artery.
Anterior to that, you will see that there is fat. See this?
Yes.
Can anybody tell me what is Stankiewicz sign? Stankiewicz sign is when you put pressure on the eye and the fat comes out. That is called Stankiewicz sign. But in the posterior ethmoidal group of cells, see this? This is posterior ethmoid artery. In the
Yes.
posterior ethmoidal group of cells, there is no fat to protect you. If you make an incision here or you injure the
Muscle.
periorbiter here, you are directly on the medial rectus muscle. Okay. You will not get a positive Stankiewicz sign in the posterior ethmoidal cells. Stankiewicz sign is positive only in the anterior ethmoid. Give me a punch. Or 1 second. Elevator. 1 sec. 1 sec. Let me just try to flick this. So where am I in right now? I am near the orbital apex. Okay.
Okay.
So this bone also will be a little hard. Why it's hard? Because it needs to protect the optic nerve. Okay.
Okay.
So let me see if I can break it. Yeah. So see, can you appreciate now, sir? This is the
Yes.
optic nerve,
Optic nerve. Yes.
Yes.
which is going to become the optic chiasm.
Chiasm.
And if you go posteriorly, you can see
Pituitary stalk.
there. That is the optic chiasm above. Okay.
Okay.
So what entails optic nerve decompression and orbital decompression is you cannot stop at this. Okay. So this is not a complete optic nerve or orbital decompression. Indications for optic nerve decompression is very minimal, like post-traumatic, if the patient is not improving, then you have to do optic nerve decompression. If there is a stalk which is, bone chip which is sitting on the optic nerve here. Okay.
Okay.
So what you need to do is use a sickle knife like this, and you have to make an incision in the sheath. Okay, this is also called as optic nerve fenestration procedure. In extreme cases, when you have raised ICT, there will be compression of this segment of the optic nerve.
Like benign intracranial hypertension.
Yeah. So see, you just this much is enough. You don't need to go very deep or anything. Just a superficial dural ring. You have to actually just remove it. That's all. Once you do that, you can start to see the nerve there below, inside. Can you see?
Yes.
See that?
Yes.
That is enough. So up to what point should you do? Actually, you don't need to come up to the midline. Why? Because here in the chiasm, no,
Yes.
the chiasm is inside a CSF filled space called as the suprachiasmatic sulcus. Okay.
Okay.
There cannot be raised intracranial pressure in that part. Okay. So when you do optic nerve decompression, you can do it up to the medial end of the carotid artery is enough up to this point. You don't need to come up to midline. Okay.
Okay.
And how much decompression of bone you should do? You should remove about at least 180 degrees of bone. See?
Yes.
180 degree of bone you should remove. So that way you will have a good decompression. Now, if you want to do orbital decompression, you have to identify this red spot. So let me just show you, like since anyway we are coming to the end of the dissection now, I will just extend this. Okay. And you will see if you make the incision here along the fat, you are in the safe zone. This sickle knife has become blunt, I think, because I've used it too much. So this is Stankiewicz sign. So when you are making the incision for orbital decompression, it has to be below this blue part. That is the muscle. Okay. If you
Okay.
make it on or above, that is medial rectus. Correct.
Okay.
So you should not make your incision. I'll just show you the rectus muscle also. See that? Can you see the muscle here?
Yes.
Yes, sir.
Can you see the muscle? If I am little far away, you can see, I think. There is too much glare. See that? Can you see the
Yes.
muscle?
Yes. Yes.
So this is the medial rectus muscle. See that? It is so close to the periorbita in the posterior ethmoidal cell. See this?
Okay.
Can you appreciate, sir?
Yes, sir.
Yes, sir.
So you have to be very careful. I have one case where one of the junior doctors actually tried to do sinus surgery. So the problem was the maxilla was hypoplastic. What he has done, he has opened into the orbit and eaten away this medial rectus muscle completely.
Hmm.
So that became a medical legal case.
Yeah.
Okay, so you have to be very careful. Okay. So I think, sir, if we need to progress, we'll probably require a drill. So I don't have that at my disposal. So I think probably we will have to stop.
Dr. Gaurav,
dissection.
in case of optic nerve decompression, if there is CSF leak, what you do in that case?
If there is CSF leak,
CSF.
why will
because
why-
optic nerve.
why will we do optic nerve decompression if there is CSF leak, sir?
No, in case of doing optic nerve decompression, when you incise over the sheet, there is
Yeah.
there is direct continuation of the CSF space.
Yeah, you will have some amount of CSF leakage, but
Yeah.
this will close. This will close. Don't worry. Put a Surgicel and put some gel foam and leave it. It will close on its own.
Okay.
There is nothing to worry there. That's a very small tear that you're making deliberately.
Okay.
So it's not to worry, sir. That is nothing to worry.
Okay.
See, the whole purpose of doing that is because you want to reduce the pressure, no? So that
Yes.
is the reason why you're doing it. So if that pressure doesn't come down because of intracranial hypertension, you want to allow this to drain somewhere.
Yeah, yeah.
The other option would be to do a VP shunt. So one of these two things you have to do. Okay?
Okay.
Gaurav, we are very happy to say that our endoscopic neurosurgeon is here. He has observed the whole dissection with you.
Yes,
And
sir.
thank you very much from all of us. Everybody has enjoyed your session. We hope we will be lucky to see you again and again here.
Absolutely, sir.
Thank you very much, and congratulations, and thank you from all of us.
Thank you, sir. Thank you so much.
Thank you.
See this temporalis muscle you can see. Can you see this? That is the vertical fibers of temporalis. See that?
I like to thank the director of NINT, Professor Jakaria sir, Professor Ashik, Professor Kobir sir, and their team to arrange a beautiful program for us. So let us have a great clap for them. Thank you. Thank you, sir, for your endeavor.
Hello, hello.
Next time.
Hello.
Good.
Hello.
Sorry. Cadaver like this.
Hello, can you hear me? Hello.
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 Yes, sir. From Shwachar Medical College, sir.
Oh, Saiful.
Sir, thank
Can
you
you
very
hear
much,
me?
sir. We are finishing and our job.
Okay. We just conclude our session, okay?
Okay, sir.
And,
Thank you, sir.
And I thanks again Dr. Gaurav Shankar for doing such a beautiful dissection.
Yes,
And
he has a
all
versatile.
and
He is a
thanks
versatile
again.
surgeon, so we'll
thanks again.
see him again and again here.
Okay, and thank you as well, you, Dr. Saiful and Shahjahan Kobir Noyan, for your kind cooperation. Okay, thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.